Hi, I'm Dr. Sridhar. Welcome to my channel. This is a quick video about when you would consider introducing suck feeds in preterm babies. So the suck-swallow coordination is the most important factor here. We do encourage trophic feeds from the beginning to encourage the gut hormone, the gut growth, the gut enzyme productions and so on. We do encourage non-nutritive sucking as soon as the baby is able to tolerate it. So a baby who is extubated on CPAP or high flow, we can start non-nutritive sucking as early as 27 weeks of gestation, or whenever the baby shows an intent to suck. So usually the pacifier is used in the beginning and we get the parents' consent for its use. And once the baby is stable enough for skin to skin care, nibbling on the empty breast of the mother is a form of non-nutritive sucking when the mother is available as well. Use of suck feeds with the bottle, we usually start around 32 weeks. We know that it's going to take time for the baby to mature the suck-swallow coordination, so we start with 1 or 2 suck feeds a day, and then depending on how the baby does, we increase the frequency of feeds. Usually the baby is on 2 hourly or 3 hourly feeds by this stage. If the baby is still on respiratory support, the baby has established chronic lung disease. If the baby looks like baby is going to wean off the support, we wait for the baby to come off the high flow to the low flow oxygen stage before we start suck feeds. If the baby is below 3 liters flow, it's a reasonably safe level to start. There are some chronic lung disease babies who are not weaning off oxygen, so in these babies we would start suck feeds and see if the baby tolerates well, we progress. So majority of the BPD babies, we don't introduce suck feeds till the baby weans off the high flow, usually with the use of nebulized pulmicort for a period of time. So the timing of this would determine to some extent the maturation of the swallow, the coordination of the breathing when the baby is swallowing. So the baby has to hold the breathing and then resume the breathing again once the swallowing is completed. There is a risk of choking or aspiration, so the nurses who feed such babies have to be experienced in feeding. They should be able to watch the cues from the face of the baby and withdraw the bottle immediately. The saturation may drop, so it may be a scary situation if the parents are around, so we have to warn them in advance what we are expecting to see. We also have to inform them that this picture changes with time. As a baby matures, they start becoming more expert, and usually we want them to reach a stage where there is no desaturation for a few days when they complete the suck feeds before they go home. So that's why the babies who are learning to suck initially, we start with only 1 or 2 feeds. So we don't want the baby to be tired by frequently trying to suck feed. We want a reasonable gap. Better to try it when they are more awake, so the nurse decides which feed she wants to offer the suck feed. If the baby doesn't seem too keen, she doesn't push the baby, and then we start it at 32 weeks because we still have at least 3 weeks before the baby can go home at 35 completed weeks, which is usually the protocol in most of the developed world. So in babies who don't progress with suck feeds, we try different measures, gentle dripping of milk, using different teats which are specialized for such babies. Use of Faberman teat, for example, which is more often used in cleft palate babies, can be considered. Using different teat sizes, brands like NUK teat, the specialized preemie teats coming from different companies, they can be tried apart from the ones which come with your ready to feed milk. So these are the different things, and involving your speech therapist who can support the feeding. It's not to hold the baby back from progressing, it's more to see what can be done to safely progress and encourage the baby to suck feed. So that's why early initiation of non-nutritive sucking, having a clear approach, non-noxious stimulation. So we should be careful with the taping and frequent feeding tube changes, because the noxious stimuli around the mouth make some aversion response which can complicate this. The babies with significant BPD are usually a little slow in progressing, and we have to inform the parents that it may take time. There are even cases where you may have to consider home tube feeding to make a safe progress gradually. And I hope this information is helpful to you, and please do share. Thank you.